I wanna hand it over to Jennifer and Megan from Children's Mercy in Kansas City. Before I do, I want to set the stage for this a little bit. So we talked, Pat and Maddie talked and presented about tools, things that they've used in their life. This presentation is going to be more focused on things that you can do together, or how you can build your team together at your care center to co-produce tools and experiences and information and resources that can help everybody, right? So how all of the members, the clinicians, patients, families, everybody can work together to develop the resources that Catalina and Maddie were talking about, and to make sure that the things being developed are useful and effective. And so with that, I'll hand it over to Jennifer and Megan.
Our presentation is a practical guide at taking co-production from a good idea to a great experience. I'm Megan. I am a social worker here at Children's Mercy. I am able to focus completely in the outpatient GI setting, and part of my time is spent with the IBD team. And then for a little over a year now, I have been able to be the staff liaison between our PrePack and our clinical team.
And I'm Jennifer. I'm a parent, and I'm also the lead for the PrePack.
So some quick objectives. We are hoping that we can help with learning how co-production has contributed to improve patient outcomes and better patient and family experiences here at Children's Mercy. Leave with practical ideas regarding increased co-production between the clinical team and our PrePack, and then identify a center priority area for patient and family co-production in your particular centers. Next. So real quick about our Children's Mercy IBD clinic. We have about 620 patients, and have approximately 80 to 100 newly diagnosed IBD each year. We have about 21 attendings in our clinic, 6 fellows, and then of those 21 attendings, 12 have some patients with IBD, and then we have 2 attendings that follow over 400 patients with IBD, and then also 6 of our fellows work with our patients with IBD. Our core QI group here is made up of 2 of our attendings, Dr. Bass and Dr. Goyle. We were able to get a nurse practitioner this past spring, which has been great. We have 2 coordinators, myself. We have a psychologist, Dr. Maddox, who's amazing and dedicated solely to our IBD program. We have a registered dietitian, and then just a few months ago, we were able to add a pharmacist who currently splits time between IBD and rheumatology.
Our PrePack has a pretty good history. We joined the Improved Care Now, or Children's Mercy joined the Improved Care Now network in 2011, and then the clinicians formed an IBD quality improvement team, and then a parent joined the team in 2012. A couple of years later, we actually, let me tell you a little bit. The parent joined the team at the request of the physician, of our lead physician. And then we formed a PrePack back in 2014, and it was organized and led entirely by the parents, primarily that one lead parent. And then our PrePack members have been involved in local initiatives and national work with ICN over the past 5 years. We have approximately anywhere from 8 to 14 parents on the PrePack. We have a formalized onboarding process, and some parents end up rotating off as their children age out of the Children's Mercy program, and some parents rotate off just as seasons of life change and things get busier and they need to change.
So co-production is the result of very intentional planning of the following: communication and inclusion, collaboration that ultimately leads to co-production, and then sustainability or planning for the future. So throughout this presentation, we want you guys to think about these 4 different areas and consider what an initial focus could be at your center. So for example, regarding policy and procedures, how does a current policy or procedure impact patient and family experience? regarding patient experience. As you design your clinic or inpatient flow, do you know if your center's priorities match the priorities of the patient and families? Education, how can you improve your patient and family education? Outcomes, what are you focused on improving at your center? Do you consistently track those results? Are there identified barriers or challenges to your improvement work? And then kind of thinking about what if patients and families could help, because they can. And we've been able to kind of develop a process here at Children's Mercy where our PFAC is highly integrated into all of these different areas here at Children's Mercy. So some lessons learned through communication and inclusion. We have our clinic team communication is very thoughtful. It's very deliberate. We have our QI meetings every other week. We have pre-visit planning and population management on the opposite weeks. We're staffing our newly diagnosed patients every Wednesday morning. We have new patient appointments, and our entire team, the core group that you saw earlier, we're all there together and constantly in communication. And then we have very formal interactions with our PFAC as well. We were able to develop, the PFAC was able to develop a plan for having 2 patients at each monthly QI meeting. And that we originally, we had one parent who tried to make the once-a-month QI meetings, and just life gets in the way and was not always able to be there. And so a little over a year ago, the PFAC started with coming up with a plan that 2 parents attend those. And then we developed a staff liaison kind of role for myself. That came actually out of an annual lunch meeting. We have a lunch meeting every July where it's all of PFAC, all of that core QI group. And then we meet each year to kind of talk about things that we've accomplished and where we want to go in the future. And one of the things that we heard on the clinical side at the meeting last July was just having kind of a more formal plan of communication between our PFAC and our clinical team. Dr. Bass, who is our lead physician with IBD, had kind of been serving in that role, but very informally. And so we were able to create kind of this liaison position that I was able to, I'm able to go to those PFAC meetings. They meet every other month, and just make sure that there's good communication from the clinic side, and that the clinic side understands where the parents are coming from. There's lots of emails, and then I think one of the pieces that makes our hospital pretty unique is the institutional support that we have, and I'll actually talk about that on our next slide. And then we have some informal communication, texting and emails between Jennifer and I. Text quite a bit and email quite a bit, and it is always very specific. It's only specific to PFAC things. There's never any patient or anything like that discussed. Obviously, it's informal, but it's also very formalized to our PFAC relationship. Next slide. So these are, so regarding collaboration, our hospital, we actually have a patient and family engagement team. So these are 2 or 3 professionals here, and their role is to kind of oversee our patient and family advisory committees. We have several. I should have had that ready.
I think we're up to 14 now.
14 PFACs. And so they oversee that, and then they're constantly bringing in that patient and the family, the parent voice to Children's Mercy. So, and that's at an institutional level, an administrative level, which I think is very helpful for our PFAC to have such an integral part into the QI team. They provide PFAC leader training, And then they also are great with being able to help communication gaps between the PFAC and the institution, or our clinical team. So PFAC comes to us with great ideas, and our doctors are on board. And then sometimes it just kind of sits because do we need to talk to marketing? Do we need to talk to IT? And so we can reach out to those patient and family engagement team members and see kind of where they can direct us, or if they can take the wheel and use their connections here at our institution. So another aspect of our collaboration is that it is, at this point with our clinical team, it's just kind of common practice for us to always, for our clinic team to always ask, what would the PFAC think? So we, in developing a flu shot letter, we send that out to our team lead to disperse amongst PFAC to get parent input. We talked about a couple years ago discontinuing infusion pre-medications. Jennifer will talk about that on our next slide, but that we had a lot of input from our lead PFAC at the time. And then at our PFAC meetings, they come up with great ideas and then are constantly asking, how can the clinical team reasonably do this? So at this point for us, the collaboration is just kind of a part of who we are and what makes up our team.
So one of the things that our PFAC does when we're considering what we're bringing to the QI team and whether or not the ideas that we're bringing are going to have a large-scale impact. We're not looking to impact just a few of our IBD patients, but we're looking to impact the whole of our patient population as much as possible. And is it going to get support from the clinical side and also from the institutional side? We can come up with some great ideas, but sometimes they don't fit. And then also the question is whether or not it fits in QI, quality improvement. We partner to some degree with CCF just in the sense that they provide a lot of educational opportunities and networking opportunities and even support opportunities. We don't feel like that we need to reinvent that. That's already being done so well. And so we're primarily focused on QI. Are we improving the outcomes of our patients? Are we improving the experience of our patients and families? And also, what kind of burden is this going to bring to the team? Is this going to be a lot of work? Is it going to be little work, high impact? There's the impact effort scale that some people use. And is this going to help? Will we help, or are we just going to create more work, which definitely is not our goal. This is an interesting idea of how PFAC, or how a communication exchange has happened in our PFAC. So you see the first little bubble, this was about dropping the pre-meds from infusions. And so this went out from our lead physician to our lead parent. And so she's like, as a parent, would you be okay with an explanation from infusion nurse regarding this change? Or would you want an explanation in a different manner? What questions would you have? Any issues we need to consider? And so, Chris, go ahead and click again and bring up the next few bubbles, just kind of go through. All of this communication happened in roughly, I think it was about a 24-hour period. And what happened is that we were able, by a back and forth between the IBD coordinator nurse and the lead physician and the lead parent, come up with a new plan and a new way of communicating with parents, but also finding out whether or not it would be okay with parents if how the communication about dropping the pre-medication meds was delivered. And it just basically came down to how it would be okay if the nurse did it. And it was interesting because our lead PFAC went in, I think, a month or two after this whole conversation took place. And that's what she experienced. The nurse came in and said, hey, I wanted to let you know that we've changed how we do some things, and we've talked with our PFAC, and this is kind of how they recommended that we do it. And she didn't realize that she was talking to the person to one of the people that was involved in the whole discussion.
This is another example of how our clinic, how PFAC kind of had a huge impact in some education. So this is our current, it's our current D-part summary that all of our patient and families receive. But several years ago, our parent group had identified a gap in care at our clinic. Parents felt that they were leaving clinic without a clear plan. So there wouldn't be much information on the D-part summary when they left, and we're having just some confusion over next steps. And so our parents developed an example of what they would like to see from the clinic. They developed a longer version of what you're seeing on the screen now. They sent it to our QI team. We had a provider that was willing to try it out, and what she found out was that it added a lot of time. I think like an extra 20 minutes to fill it all out, and obviously that adding that much time to a clinic visit is not an option. And so came back to PrePack and just kind of asked how it can be condensed while keeping the same content. And so several changes were made, and this was created. And at this point, it is standard practice. Every single one of our providers who work with our IBD patients use this, and it's now part of our the electronic medical record here in the patient chart. So what was needed from this was two things. We had to have a doctor that was open to change, just to changing and hearing this idea, and that's what Dr. Bass does for us. And then we needed a PFAC that was able to, parents that were able to identify a gap in care and feel comfortable to bring that to our attention. This was kind of a longer process. It took, like I said, it took a lot of kind of communication back and forth, but it ultimately, this quote here, it changed how I practice. That's a direct quote from Dr. Bass, and I mean, she talks about this kind of collaboration, co-production success frequently when talking to our PFAC, about our PFAC.
One of the things that we discovered as I came onto the PFAC, I've been on the PFAC for about 3 years. We had an awesome lead parent, but she was also feeling, like we talked about how seasons change and life changes, that there was a lot of burden on her. And so we needed to come up with a plan for leadership transition and to formalize our PFAC processes and some of just how we operate in order to make this sustainable. And so one of the things we did was we took probably several months to almost a year working on our mission, our vision, our key driver diagram, which you'll see in a little bit. And we came up with some role definitions and some responsibilities for the roles. Like for me, I'm the PFAC leader, so I'm the primary contact person that the clinical team will contact. And then I disseminate information via email and other electronic means and so forth to our PFAC members, and then organizing the group and so forth. We also have an official onboarding process where we, as we bring people on board, they have to go through the Children's Mercy volunteer process, but there's also a process that they go on board with us. Part of that process also includes learning about ICN and how we relate to ICN and use the ICN metrics and so forth to measure our quality improvement and how we're doing. So all of that has enabled us to look for the future and to be able to continue this great partnership that was started with one parent several years ago. This is a slide that kind of shows a lot of the products of our co-production. And I can't remember, Megan, if I was doing this one or if you were.
I'll let you take care of it.
But, sure. These are just a few of the things that have come out of our work with the clinical team, our PFAC work. One of them is a flare algorithm. We had parents that were wondering, when do I need to call the doctor? When do I don't need to call? You know, when can I just send a message through the portal? When do I need to go to the hospital? And so we, alongside with the clinical team, we developed a flare algorithm so that it was kind of like one of these things where if this is happening, then you need to do this. If this is happening, then you need to do this. And a lot of our parents have found that extremely helpful. Something else that we did was an IBD school letter. This goes out to with patients so that they can take it to their schools. It's got information for school personnel about how to help IBD patients at school. One of the things that the PrePack did in that letter was first of all, we reviewed it for information, but most recently, we added a little piece in there along with Dr. Maddox regarding trauma-informed care, because we've discussed about how IBD testing, IBD treatment can be very traumatic, especially for younger children, but also for teenagers. We developed a family handbook. We've reviewed the young adult clinics, transition and transfer discussions. The PrePack's written a letter to families after a new diagnosis so that they know who we are and so that they know how to contact us. One of the bigger projects that's been going on at our center is the MyCare app. This is a phone application that integrates symptom management, medication adherence. It's gamified so that patients are given rewards for adhering to medications and to tracking their symptoms. Eventually, we hope that this can be directly connected with the EMR, the electronic medical records, so that a physician can pull up a patient's kind of history of symptoms. We found that this is going to be probably pretty helpful, especially for teenagers. I don't know about you all, but my teen kind of forgets when she's been feeling bad and when she's been feeling good and what's connected to it. So they can track a lot of things with this app that will give the provider a lot more data and possibly improve their treatment. The other thing that we've been working on is a communication tool. We've had some parents who have struggled with how they actually feel about the treatment plan. And so one of the things that we're working on now is developing a feedback tool so that when parents get a change in the treatment plan or something added to their treatment plan, but they're not sure about it, they can, this is essentially an electronic tool that'll feed back to the clinic to let them know, hey, I'm on board with this, I'm good. Or they can say, I'm okay with this, but I might need some help. Or they can say, I don't know about this, can you please follow up with me? And the last would be that they would say that, no, I don't think I can do this. Depending on how they answer in that communication tool, the clinic will automatically follow up with them within a certain amount of time period. Obviously, if the answer that is, hey, I'm not comfortable with this at all, they'll get a follow-up within a day or two. And so it's just a way to help increase communication and increase care, and hopefully educate parents better about the treatment plans that they're receiving, but also hopefully improve outcomes by catching things early on before things get out of hand. And of course, we already talked about our D-part summary. And then we also have direct mail and listserv communication with families. Our clinic is working on sending out newsletters with educational pieces and other information, and some inspiring stories too that has helped. So,
and the MyCare app is pretty fascinating because it's a huge project. It's been, I think, in development for probably the last 2.5 years. That has the potential to kind of go across our hospital system. But it literally started in a basement meeting room here, here at our hospital, with our group of parents. And it has morphed into a huge project involving our philanthropy department and just a lot of
innovation teams. Yeah.
It's been a really fascinating and cool experience that started with our PrePack.
And they hope at some point we have essentially kind of ownership of it in the IBD clinic, but the dream of the hospital is for this to go system-wide. oncology is looking at it, and several other departments and specialties are interested in it as well. One thing I forgot to mention is that the MyCare app also includes a mental health piece, so that folks can, so that patients can track where they are mentally. We are working very, very hard in that area, and really are starting to recognize the mental health aspect, especially of IBD and other chronic diseases. And so we're really excited about that app being able to go into production. It's actually in beta testing right now. And so we're pretty happy about that. And again, it's something that it's possible that it's going to go system-wide. And as a parent, I'm thinking, wow, the work that we started in that little basement room with, I think, pizza that night has the possibility of impacting not only the 620 IBD patients that Children's Mercy serves, but a whole lot more as it expands to different specialties. I think we can go to the next one now.
And so just reiterating what I think Chris said earlier, just thinking, you know, by next Tuesday, what are some changes or some ways that you can identify at your institution to kind of start looping in the parent voice from a QI, with a QI perspective. And I think the next few slides are just, yeah, questions, and then we are finished.
Yeah.
My question, maybe a quick piece of advice. If there is somebody on the call who is a clinical staff member who wants to get a parent or patient involved, or a patient or parent who would like to get involved, like, how do you recommend making that first connect? Like, what is the first thing they should say? Do they just start like asking people? The very first, they're sitting here and they're like, that all sounds great, but I don't know how to get started.
Yeah, so I think what Dr. Bass has shared is she knew Jamie Hicks was our lead parent before Jennifer, and she was Jamie, the doctor for Jamie's child, and Jamie had some qualities that, I mean, it's very deliberate and very thoughtful person to identify. You definitely want the right person. And so Jamie came with lots of questions, lots of detail, and it was right when, you know, we were kind of starting our journey with ICN, and so she identified that person, Jamie, and I think the key is, you know, we're talking about very large projects, but it's to start out very small and very deliberate, and what is one area that you can focus on, and then from there build out. Because what we're sharing is 5-6 years of co-production. And so just being very deliberate in who that parent partner could be, and then starting very small.
And I think from the parent side of things, one of the things is that Megan mentioned that Jamie was, you know, asked a lot of questions and was very, I guess, detail focused and so forth. Dr. Bass shares stories about Jamie showing up with her 3-ring binder to appointments and stuff in the hospital. So, but from a parent side of things, I think it's one of those where it's difficult sometimes to approach providers, but I have really started to figure out that the providers at Children's Mercy are very open to parent input. Now, I have met with some parents who have said that at their place, and I don't think it was an ICN, I think it was with another group of parents I was meeting with at one point, that said that their clinicians would never want a parent to sit in or a family member to sit in. And it reminds me of a saying that someone once told me, that slow is fast and fast is slow. Clinicians and clinics can go ahead and go forward with all their policies and procedures without parent input, but then they might end up having to revise a lot of those policies and procedures and keep revising and keep revising. And I liken it to quality assurance testing in the in the IT world where it's easier to test something in a test environment with parents on a PFAC than it is to rewrite the code after it's already out into production. And so if clinicians and providers can consider that, it might save a lot of headaches and a lot of work in the long run.
And I think too, and before I see Judd's question here, but I think too, if you're at an institution and they have the PFAC as part of the hospital, reaching out to whomever is in charge of those PFACs and seeing how you could get one started. They will have lots of resources as well.
Thank you so much. This is fantastic and groundbreaking work, and I'm excited that we're going to get to learn together and continue to do this work together in the future.